welcome you to the Patient-Centered Primary Care Collaborative's National Briefing. The topic today is integrating peer support into primary care. I would strongly encourage those of you who have not done so today to not only join us for this fantastic webinar, but also go to pcpcc.org and take a look at the monthly newsletter that we just sent out this morning. The topic for February is Love is Patient, as in Patient-Centered Medical Home. And I think it is appropriate, given that I think a little patience is required across the broad stakeholder group of folks who have long been pushing for patient-centered medical homes. I know some folks are discouraged by a JAMA article that came out this week that didn't seem particularly supportive of the notion of patient-centered medical homes. The good news is we've got 54 other studies to share from the last few years that do point to some positive findings around PCMH. And of course, this model of care continues to evolve, which does indeed require patience from all of us. With that, I am so happy to tell you about a few things going on at the PCPCC and then turn it over to our special guest today. First, I think many of you are aware our monthly briefings are now in a webinar format. And in that format, if you'd like to ask a question, and we'll be opening up a Q&A at the end of today's briefing, you're going to need to put it into the question box that's provided by the webinar software. Also wanted to let you know in this new format, we are going to be providing the slides and the presentation on our website. We'll post it within the next 24 hours. So with that, I am thrilled to introduce our two guest speakers for today. First, we have Dr. Ed Fisher. Many of you are familiar with Dr. Fisher's work. He is the Global Director of Cures for Progress. It's a program of the American Academy of Family Physicians, of their foundation. And it promotes peer support in health, healthcare, and prevention around the world. I will just tell you, without reading in great detail all about Dr. Fisher's background, for any of you who have loved ones who have been ill or who themselves suffer from a chronic disease, you understand the importance of having someone who is going through the same set of circumstances that you are to provide support, assistance, comradeship, and Ed's research is again and again pointing to the effectiveness of using peers in a way to support those patients that literally impacts their outcomes and their progress. And so I'm thrilled that he was able to join us. He, of course, is a nationally, actually internationally renowned researcher. And again, you can read Ed's bio on our website. Then we have Leticia Ibarra. She's the Director of Programs at Clinicas de Salud de Pueblo. She's new to the PCPCC, but certainly not new to this field. We are thrilled she was able to be with us today. She did her academic training at Harvard, where she got her BA in psychology and her MPH from the University of California School of Public Health. She herself has done many peer-reviewed publications and has a number of academic honors. And she's going to be telling us about her work in immigrant communities using this model. And again, there's so much here that we have to learn. I'm very appreciative to those academics who are not only demonstrating the importance of this kind of model in helping those patients, but in literally improving the outcomes of population health. So with that, I'm going to turn this over to Ed and thank him and Leticia for being here. Thanks, Ed, and feel free to get started.
Terrific. Thank you, Marcy. It's really a pleasure to be here, or be with you all, I guess is more appropriate. The PCPCC is such a wonderful organization, and it's really a delight to have the opportunity to talk about this work that we love through the PCPCC channel. I also want to express my personal pleasure in working with Leticia on this webinar. I've known Leticia for a few years. Uh, she and her colleagues in San Diego worked with us on a project, and I've just always learned things from hearing Leticia talk about this work. There's the old adage, those who can do and those who can't teach. I think I fall in the latter category and Leticia in the former. And so I'm going to try to get through my slides in about 15 minutes to allow lots of time for Leticia to talk about some of the practical experience that they've had in San Diego that I think will really be valuable to those of you on the call. So as Marcy mentioned, I have the privilege of being the Global Director of Peers for Progress. Peers for Progress is a program of the American Academy of Family Physicians Foundation, and we're focused on promoting peer support and health care and prevention around the world. And this is our website. I invite you to visit it. In addition to having information about peer support, it also has what we hope is a very valuable set of documents and resources and pieces that are useful in planning and implementing peer support programs. As Marcy mentioned, we've had the good fortune of working with colleagues in a number of places around the world. The black dots are the original 14 grantees of Peers for Progress. Leticia's project with her colleagues at San Diego State University is the black dot on the southernmost part of California there in the map, and then the red dots are a subset of other groups that we've developed collaborations with over the years. I want to spend a few minutes talking about definition and foundations because I think in some respects where you start is very important. Talk a little bit about what is peer support. I suspect most of you on the call have some sense of this, but we're using peer support here to refer very broadly to community health worker, lay health advisor, promotores, coaches, navigators, a variety of programs in which non-professionals, sometimes they have the problem, sometimes they have a close relative or friend with the problem, or sometimes they're trained to understand the problem, but non-professionals help people manage a disease, deal with the disease, deal with the distress of a disease, or prevent disease through challenging behavioral changes like quitting smoking or managing weight. Peer supporters can be volunteers. Sometimes they're reimbursed with stipends. Sometimes they're paid staff. Some are community-based, some are clinic-based, some are a combination of the two. In Peers for Progress, we've found it helpful to emphasize 4 key functions of peer support. They're very simple, but they turn out to be a pretty useful template for thinking about peer support programs: assisting in daily management, social and emotional support. Chronic disease gets old, people have stress, having somebody to talk with can be helpful. Linkage to clinical care, making sure that people get the clinical care they need and making sure that people are aware of community resources that can be helpful to them. And ongoing support. Most of the issues that we're dealing with are not like the flu. They're more like diabetes or trying to manage weight for a long time. They need ongoing support. It turns out that if you ignore behavior, it tends to go away. And so we need ongoing support to help people maintain challenging lifestyle patterns and chronic disease management patterns. I want to talk about the fundamental role of social support in human affairs. Most of you who've taken a freshman psychology course have seen the picture at the left-hand side of the page here. It's a picture of a study by Harry Harlow back in the middle of the last century. And Harlow showed that when it isn't hungry, the little baby monkey stays close to the terry cloth mother with a relatively friendly face rather than the wire mother that is the source of food. And what Harlow showed by this and a bunch of other studies making a similar point is that our need for what he called contact comfort is a fundamental characteristic of primates. That includes all of us. You hear talk about men are from Mars and women are from Venus, and different people have different needs. We all do better when we have somebody that we can talk to, somebody who cares about us, and somebody who can help us. Not only do we do better, but we live longer. As at the lower right-hand side of this slide, the risk of death associated with lacking social contact is greater than the risk associated with cigarette smoking. So when we're talking about peer support, we're talking about a very fundamental and very powerful influence on human behavior. I think this is really important because there's a tendency to treat peer support programs as frivolous sort of things that health systems might do almost as a public relations strategy. Let the candy stripers do it. It'll make some people feel good and get us some nice pictures. We feel that peer support can be a very powerful and important part of healthcare, of primary care, of the patient-centered medical home, and I think essentially the balance of this presentation is to talk more about that. There's a reason that we think peer support is important in diabetes management and chronic disease management. I apologize, some of my slides refer to diabetes, some refer to disease management. A lot of our work has been with diabetes, but we really extend it to chronic disease prevention and health in general. Here are some of the reasons that peer supporters can be valuable, especially those two in the middle. They share the perspectives and experience of those they help. People tend to believe others who are like me. If the doctor tells me to exercise 150 minutes a week, I probably accept that that's important. But if my friend who has a similar situation as I tells me how they're able to exercise 150 minutes a week, it makes me much more likely to think that I can do it. So we look to experts to tell us what's important. We look to other people like ourselves to tell us what we can do, what will make sense for us. And the other thing is that peer supporters have time. We know from a lot of research that the amount of time we spend with patients or individuals in prevention settings, the amount of time is often a pretty good predictor of how much impact we'll have. I want to talk a little bit about evidence. We have conducted a systematic review among peer support programs across a whole bunch of chronic disease management and prevention issues: asthma, diabetes, obesity, smoking cessation, HIV, mental health, etc. Cutting to the chase, about 83% of those reports showed significant impacts of peer support. So there's quite a bit of evidence that peer support works. In diabetes management, in the first 10 years or the first 12 years of the century, we identified 14 studies that had pre and post hemoglobin A1C values reported, and we found that on average they showed a decrease from 8.6 to 7.8%, which was highly significant. So there's, again, a lot of evidence that peer support works. This is a report from Health Affairs a couple of years ago on 4 projects that Peers for Progress supported in Cameroon, South Africa, Thailand, and Uganda. And as you see there on the left, they showed reductions in clinical indicators, improvements in a whole bunch of health behaviors, increased contact with primary care, which is an important impact from the perspectives of, I'm sure, many of you on this webinar. And several of the programs showed sustained and even increased participation 3 years after the funding ended. Here's a project in Vietnam. I won't go into the details, but it had a 4-week class led by a nurse, and then the peer supporters attended those classes and were introduced to the participants at the end of the classes, and then they provided ongoing support for another 5 months. And you can see graphed there the increases in self-care behaviors and the decreases in hemoglobin A1C in the intervention group relative to the control group in that project. In San Francisco, Tom Bodenheimer and his colleagues randomized people who were being treated through safety net clinics associated with University of California, San Francisco. They randomized people with diabetes to a coach or a usual care condition, and you can see that in the coach condition, they achieved a reduction in hemoglobin A1C of over a point relative to about 0.3 of a point in the control condition. Beyond chronic disease management or beyond clinical management, a lady health worker program in Pakistan trained lady health workers who are a routine part of the primary care system in Pakistan to provide problem-solving and cognitive behavior therapy for women who were depressed during the 3rd trimester of their pregnancies. And as is graphed there, you can see that they reduced postpartum depression 6 and 12 months after delivery by over 50%. So peer supporters can also learn complex psychological interventions and implement them with positive effect in such as in postpartum depression. Cost effectiveness, there's a lot of research increasing now showing cost effectiveness of these interventions. I won't detail all of these, but just to point to them, and of course the slides will be posted and you can revisit those and get the references if you like. A really important aspect of peer support is what we call reaching the hardly reached. That is, they're available, that's just that we hardly reach them. A good example of this is the project that I mentioned earlier that was done in San Francisco. You'll recall this slide from a couple of minutes ago. What was really perhaps most interesting about this project is that the investigators broke out the patients according to a measure of medication adherence that they had given at baseline. And they divided the group up into those who were low, medium, or high on medication adherence at baseline. And what they found, as portrayed here, it's circled, is that those who were low on medication adherence showed the greatest differential benefit between the control condition and the peer support condition. As you can see, reductions in hemoglobin A1C were greater among all 3 groups subcategorized by medication adherence, but the biggest difference was in those who were poor on medication adherence at the outset. So there's evidence here that peer supporters are able to reach the people that we all scratch our heads about a lot, those that we too often fail to reach in our prevention and disease management programs. Another example of this in a program for mothers, single mothers of Medicaid-covered children who'd been hospitalized for asthma in St. Louis. The mothers and the children were recruited with a commitment only to complete the assessments, not necessarily to participate in the intervention. And so therefore we were able to assess the reach of the intervention to this sample of single mothers of Medicaid-covered children. And the coach was able to achieve substantive contact with these mothers, 35% within 7 days, 89% within 3 months of the time they were randomized. So again, the peer support, in this case asthma coaches, was able to reach those we too often fail to reach. And to good effect, in the coach condition, rehospitalization was reduced by half relative to the control condition over 2 years. Want to turn to peer support in primary care. I'm sure everybody on this webinar is familiar with this graphic of the patient-centered medical home. I'm sorry, my my slide here is a little bit strange, but community outreach is a key component of the patient-centered medical home. But as you know, there are important challenges in this. It takes a while to nurture community relationships, and community outreach programs sometimes have rather imprecise reach. You perhaps have had the experience of spending a lot of time getting together a program, for instance, a community program for weight management, and when you finally get it up and running, it seems like those who are coming to it are vegans who run marathons rather than the people with high BMIs that you were hoping to reach. So one of the things that we think peer support can do is really help us reach those that we're needing to reach when we're trying to find people who have high risk or disproportionate disease burden, etc. Here's an example from a private practice in a New York setting. They hired a half-time outreach worker, had them do a variety of things, and they had increased rates of preventive care like mammograms and immunizations, and also improvements in glycated hemoglobin measures of diabetic control. So here's an example of just hiring a half-time outreach worker in a primary care setting and seeing good effects of that contribution. We think that peer supporters have advantages because we recruit peer supporters frequently from the communities we're trying to reach, so that there are intrinsic community ties then between the primary care setting and that community provided by the peer supporters. As we've discussed, peer supporters can reliably reach those of greatest importance, as in the Asthma Coach project, and we're currently testing this in a collaboration with Alivio Medical Center in Chicago, in collaboration with the National Council of La Raza and TransferMed, and that's funded by the Bristol-Myers Squibb Foundation's Together on Diabetes program. In working on this, we've thought a little bit about what's our model for the roles of the peer supporter and the clinical team. If you think about it, the person with diabetes, they're concerned about everything from major general goals like living to be 80 and specific behaviors like taking a walk after dinner. The physician starts pretty much toward those goals and works through objectives like losing 10 pounds or trying a new statin. Other members of the clinical team may move a little bit farther towards specific behaviors, but it's really the peer supporter who's often the best person to take the objectives that are worked out with the clinical team and extend them and problem solve and troubleshoot with the patient to turn those into specific behaviors. I mentioned the program with Alivio Medical Center. One of the things that we're trying to do there is reach the entire population of 4,000 people with diabetes. Many programs work with a few hundred people who join or otherwise find their way into the program. Here we're trying to say how can peer supporters work with an entire population of people with diabetes or another chronic disease. We've identified out of the 4,000 about 500 who are high priority in terms of A1C levels, psychosocial distress, or physician's referral, and then also the normal priority. And the high priority get more individual contact, coaching on regular care, diet, assistance with other problems they may have. The normal priority are contacted more through support groups, activities, contacts during clinic visits, etc. And you can see there the graph. To date, we've achieved contact with about 469 of the 500 high priority people, and it's taken us a little while, but we're working up to about 1,700 of the 3,500 who remain. So we're seeing this as just a simple model, of how a peer support program can address an entire population of people with a health condition and not just the few hundred that find their way into a program. I'm going to go very quickly over future directions. We think there's a lot of role for peer support in reducing rehospitalization. Bulleted here are key findings from an RWJF report a year ago on strategies for reducing rehospitalization. You can see that peer support could contribute to virtually all of these. In terms of, again, here's a wonderful paper from almost 20 years ago now from an old friend of mine from St. Louis, Mike Rich at Washington University, who developed a very nice program for reducing readmissions through heart failure. I won't detail the intervention here. It was delivered by a research nurse, but for research purposes. But as you can see, by looking at the details of the intervention, again, a peer supporter could do most of those things. Here is a study more recently in reducing rehospitalizations in Medicaid, and I've just sort of initialed the intervention emphases that seem like things that peer supporters could readily do. And finally here, follow-up after major procedures, joint replacement, transplant, hospitalizations for MIs, etc., or for behavioral health, mental health, where adherence, follow-up, maintaining contact, encouraging people to get in for regular care as they should, etc. All of these are objectives in reducing morbidity and reducing unnecessary care after major procedures or in behavioral health issues that we think peer supporters can make strong contributions to. Finally, the Affordable Care Act offers the health home, which is a add-on to the patient-centered medical home, addressing people with chronic diseases, several chronic diseases or mental health problems, and again, peer supporters could be instrumental in providing these services. So thank you. There again is our address, and at this point I think I turn it over to Leticia.
Thank you, Ed. It's an honor for me to be here with you and Marcy and the rest of the PCPCC team. So I'm going to go ahead and get started. So I'm going to be providing some examples from us here at Clínicas de Salud del Pueblo. Okay. Okay, so in this presentation I will present some of the challenges in trying to integrate peer support into primary care in primary care settings. A couple of examples from the clinic and some of the lessons we have learned across our time and integrating peer support. For us, the broad themes in terms of the challenges for integrating peer support have been ensuring that it's a good fit with our setting. And not in terms of, by setting we mean the community and infrastructures in the community. Then within our organization, thinking about our just what is our hierarchy, what are our facilities like, and then also making sure that it's a good fit with health issues that we're trying to address. And some of those big themes within that have been whether it's culturally acceptable and appropriate for us, whether it's systems, whether we have systems and infrastructure in place, whether we should have paid versus volunteer peer supporters, whether the support that they provide is a one-time event or something that is a series of sessions or contacts over the long term, whether it's 4 weeks, 6 weeks, or more than a year, and then whether that contact is with individuals by themselves or group-based, and then whether that contact is on-site versus off-site. And so for Clinicas, in terms of those challenges, for us we have really felt that we've already kind of know the answer for us, especially within the first three. We are convinced that it's an effective model for our patients for a lot of the same reasons that Ed has said previously. And we have, and I'm going to describe a little bit more of how we came to that understanding ourselves too. We have incorporated some departments and policies devoted to peer support, community health outreach, and education in the organization and the structure. And we also believe in paying peer supporters for the dignity and value they bring and the quality of the services that they're providing, and also to ensure longevity with some of the services that we provide. Even though for us, I mean, how we pay the peer supporters does vary a little bit based on the funding that's available and the nature of the program. And so the biggest challenges, I guess, and the questions are the remaining three that I had mentioned before. To give you, I have to remember that this advances kind of slowly. Okay. To give you some background, so Clinicas de Salud del Pueblo is located in the southeastern corner of California, and so we basically cover an area that is about the size of the state of Connecticut, and it covers the entire Imperial County area and also parts of East Riverside County, which are directly east of San Diego and southeast of Los Angeles. We are a rural area. And agriculture remains a big industry in this area thanks to irrigation. We are also getting some new renewable energy projects in the area. As you see with one of the pictures down there that has the windmills. We also have more solar panel projects coming out here to this desert area. Because we are a rural community, we do have a big reliance on cars. There isn't much public transportation because everything is spread out so much within this geographic area. And we do face also extreme temperatures in this part of the world. And we have, because we have a very low socioeconomic level in this area and also low education levels, and many of our residents are Spanish speaking, and that's largely due to the fact that we are a border community as well. We border Mexico. And so all of those things kind of impact the health of our local residents. And so here in Imperial County, we face many health issues. We have high rates of diabetes, high rates of cancer, asthma, obesity, hypertension, and heart disease. And as you can see, those are many of the chronic diseases that we're seeing in not just this area, but in other parts of the country. In terms of our, who we are as an organization, this clinic was started in 1970 as a farm worker clinic, which many of the community clinics actually were back in that time. But today, the health centers are open to everyone. And we started with 3 community health centers in 1970 that were very small, as you can see with one of the pictures that's there on the screen. And now we have 11 comprehensive health centers, 3 dental clinics, 3 women, infant, and children programs, the WIC programs, 2 community health outreach departments, and 350 dedicated professional health care staff, which includes physicians, dentists, and mid-level clinicians. We do see over 204,000 visits a year with more than 56,000 patients. And now, even though before we started as a farm worker clinic, now farm workers only make about 9% of our population, but it's still a very important group that we serve. In this slide, too, one of the key words that we have there is a comprehensive health center. Clinicas has always saw it, and as the needs of our community evolved, we have seen that it's important to be a one-stop shop for our community. In Imperial County, we are the only community clinic in the area. There are a couple of lookalikes, but we are the only federally qualified health center in the area. And in Riverside County, there are a few other community clinics there, but in the towns that we work in, we are the only community clinic that's located there. And many times there aren't any other private offices available in some of the medical offices available in some of the towns that we are located in. And so because we do want to be a one-stop shop, we do try to offer pharmacy, lab, radiology services in addition to the medical and dental services within these centers, and also health education and health promotion. But one of the challenges that we face that probably other health centers are facing is that as you're growing, as the population has grown, that needs our safety net services, we are challenged to find the space for more exam rooms, and so what sometimes has happened in our health centers in terms of infrastructure is that we convert more offices and health education rooms into exam rooms, and then what happens with our health education staff is that they become a little bit more mobile, and so have to learn to be, I guess, have all of their materials and supplies within a bag or a little suitcase that they can pull around. But we have learned to work with those sorts of situations. In terms of our structure, and we are still structured more like a traditional federally qualified health center with board members being made up of consumer members and professional members, and we have many of our senior management team members devoted to the clinical and medical dental services that we are offering at our health centers. But since about the 1990s, we expanded to include a community health outreach department, which is directed by the director of programs, and then later on by the director of public affairs. And the reason why we have those two is because we did have one community health outreach department that was just based, well, the office was based in Imperial County that was trying to serve both of our residents in Imperial and Riverside counties, but trying to always be careful about serving the specific needs of our local communities and being place-based, we felt the need to have a Riverside County office. And so the Director of Public Affairs came on just a few years ago to lead a department out in the Riverside County area for us. And just so you know, there's about a 60-mile difference between one of the larger cities in Imperial County and the Riverside County site that's closest to us here. And so, that can be pretty significant in terms of some of the different community issues or factors that you see. And so we wanted to be responsive to that. And so in having these departments, we also, like I said before, we have policies and in place with an organization to be able to have a community health outreach team and staff. And some of the policies that we follow for our staff can be different from some of our regular staff. For instance, because we did start off in the early 1990s with our community health outreach to serve more of our farm working community, we had more traditional promotora models at that time, which was that most of our community health workers or peer supporters were Spanish-speaking. And they were local women that, were local counselors, just lay counselors for their friends and their comadres. And so they were brought on board with the clinic. And so we had to come up with policies that would help not only embrace them, especially, again, like being able to have first some of our policies in Spanish as well as English, and also to have staff that doesn't understand English, be able to work comfortably with women who were primarily Spanish-speaking and working out in the community. We had to have more flexible schedules for our promotoras, and so that was built into some of our policies and procedures here. And one of the things that you'll notice here, so that with our programs, and that we have been trying to develop these programs to address emerging issues in our community's health, you'll see that we have several programs that are devoted more towards prevention and promotion of disease prevention. We have several programs that are now dedicated to chronic disease management, which has developed over time. That wasn't always the case. I think before we used to focus more on prevention and healthcare access than we did on chronic disease management. And as our patient population grew, we did also expand to other types of peer-to-peer models or mixed models to also serve our community that was English-speaking or preferred English, even if they were Hispanic. And so we did try to incorporate some different models that could serve our patients in ways that were more familiar and effective for them. One of the things that in the slide, the reason why we have 3 programs highlighted in red is because those are the only programs that are exclusively based within our healthcare sites, our healthcare center sites, the clinics. All the other programs either have some components that happen in the clinic, but most of it is actually community-based. So our community health workers, our promotoras, are going out into the community to offer the diabetes classes, to offer the healthcare access information that our community residents need. And so, and that is one of the things that I think sometimes when we think about integrating peer support into community clinics, we only think about bringing them in to the clinic and having them on site with our patients, which is important, but for us it's always been important to have them out in the community and to be a face of the clinic out with our local residents. It helps our local residents get more familiar with the services in a way that that they understand and that seems familiar, but also to feel that it's an organization that represents them and that is looking out for their needs. So, and as Ed had mentioned before, we found that all of these programs, having this, and we knew that this was going to be a good match with our clinics because, in Latin America, there has been a long tradition of promotoras, lay health advisors, how they many times are called, and just, a mother-in-law or a mother, advising a daughter in terms of how to, take care of their needs, and even men, receiving advice from traditional healers, and so we knew that that was something that our community, because it was largely Hispanic, was familiar with, and that they were used to receiving that sort of information from in their home, and maybe from someone that they might not know too well, but they have heard of them, and that they were respected or recommended by someone that they knew. And so coming from that tradition, we knew that this was going to be an acceptable and appropriate practice for us to adopt in our clinic. And so, like I mentioned before, we did adopt this within the early 1990s when it was becoming more apparent that our community clinics were maybe not being as patient-friendly as they could be, and were too stuck in a medical model. And one of the things that we have found, which is in this next slide, is that it has led to having peer supporters working with us in the clinic has been empowering our patients and building the social capital in our communities. And so through family contacts, through contacting them in a clinic, or reaching them through groups, we have been able to build some really meaningful, skills and abilities and knowledge and confidence in our community residents. And we, as an organization, find that very, very helpful. I think sometimes, people feel that our community health workers sometimes become too much of an advocate, and that some of our patients are too outspoken. And we actually have to do some education with our providers sometimes in terms of helping them understand that that's a good thing, and that they're really just trying to, they're getting a voice and are finding a way to really be more present in their healthcare. And so so we know that it's also a two-way street, and that we, as we work more with our patients, that we also have to work with our staff in helping them prepare for these meaningful contacts with the patient. One thing I wanted to mention before in terms of the promotora and the peer-to-peer, and I had mentioned that the promotora model are more of our Spanish-speaking monolingual community health workers. But in our peer-to-peer and mixed models, that's where we've had more of the bicultural, bilingual staff, serving the various different populations, whether it be adolescents or HIV men who are HIV positive, and others in our community that might be more acculturated into our communities here in the United States. And so we have found that, and when we work with more bicultural, bilingual people, that it is a slightly different cultural environment as well, which is important to be in tune to, and that we don't try to impose one way of working with one group into another one. We try to be responsive to the slightly different cultural norms that might be happening within our patient population. Okay, so in terms of providing some real examples about how we try to address the challenges and prepare our integration of peer supporters into some of our different services, I'll go into the example of our Puentes program, which was funded by the Peers for Progress program and the American Academy of Family Physicians. With this project, we were trying to increase asthma control, diabetes control for our Spanish-speaking patients here at Clinicas. So in a way, we were following a little bit more of a traditional model with this one because we were working with only Spanish-speaking patients. We did recruit more primarily monolingual Spanish-speaking community health workers for this. And we worked with them with the 4 core functions for diabetes management, which were assistance in daily management, social and emotional support, linkage to clinical care, and ongoing support. And we were following a chronic care model. And in looking at how, because we also felt, even though they have these 4 functions, that the main place where some of our patients here in Imperial County needed more support was in that social and emotional. That was one of the areas that was creating the most, I guess, barrier to our patients being compliant with the medications and being adhering to the clinical exams, and so we knew that was going to be one of the areas that we needed to emphasize a little bit more. And here you're seeing some pictures of some of our community health workers during training and dinners with our community members. And so what we decided was, because our patients needed a little bit more individual, emotional and social support, that it needed to be individual support. And so, we needed to have at least a contact during the first 6 months. And this was also based on some of the literature in terms of trying to create, lasting changes with diabetes control. And so again, we made it individual in order to be able to have this lasting support within our population, and to be able to offer a little bit more emotional and social support. And so we made it more individual. We decided to leave it up to the community health workers and the patients themselves to decide whether they wanted to do the contact by phone, or in their home, or at the clinic during a clinic visit, or in a support group. And that, again, was to, so that the CHWs and the patient could also see what their needs were and then be able to respond in the most appropriate manner. And the CHWs were trained in all these different modes of support. we recruited 30 peer supporters, 3 groups of 10 peer supporters, because we based them in 3 main communities of Imperial County, which is also known as Imperial Valley. And because there were so many, because we wanted to provide individual support, these peer supporters were actually paid by stipend, just to make it a little bit more affordable. And it actually was, and they were recruited as volunteers with just a small stipend to help with transportation costs. Which was, like I mentioned before, I mean, transportation is a big issue in Imperial County. Our distances between towns and even across one town can be considerable, and public transportation not easily accessible. And our peer supporters, because they are like our patients in many respects in terms of the economic level, education level, they might have limited resources for it. So we did offer that. The way they were integrated into the rest of the clinical care for our patients was that even though it was community-based, it was happening in their home, ad hoc in the clinic visits, or through support groups that were also either, they could be based in the home, in a community center, or in the clinic. Because it was more community-based, the way information was reported back to the clinics was how I guess it was integrated, and it was basically their reports were placed into patient health records. And because most of them were Spanish-speaking, the way we had to do it in terms of getting their information into their health records is that we did work with a couple of the peer supporters that were bilingual and had them help translate some of the reports from other members, or we have myself or a coordinator translating some of the reports to be able to insert them into the health records system under patient-provider communication. And well, before it was actually a paper chart, but then we have since transferred into electronic health record, and we put it into that field.
Leticia?
Yes.
This is Marcy, and I just want to be mindful of the time, and you've got folks who have some wonderful questions for you, and I'm going to throw a few of them at you now because it's relevant to what you're talking about. So you talked about a stipend for the community health workers or the peer supports. Where does the clinic get the money to pay for these peers? Do you provide services to folks who suffer from addiction? Who provides the training for the staff? These are just some of the good questions that are coming in the door.
Yes, great questions. For most of the work that we've done with community health workers and peer supporters has been grant funded. So one of my main jobs is to constantly be looking for grant funding for all of our programs. For the programs that have been based in the clinic, we have been able to get sufficient reimbursement from the clinical visits to sustain those activities. And so that's one of the reasons why we only have 3, because it's there still have not been enough reimbursements with some of the other programs to sustain that peer support, that health education. The training is also provided by myself, and we also look to partner with community partners, like the Public Health Department, like San Diego State School of Public Health, and other promotora organizations that work throughout the state. Like here in California, we have Visión y Compromiso, which is a statewide promotora CHW organization, and they provide a lot of training for staff. We can go ahead and skip the HIV care program slides. You should have them available to you after this presentation. And just, one of the big differences is that this one was based in the clinic, and this does have all paid staff, with our peer health educators and our case managers being the only full-time staff for this program. The others are only available for HIV primary care clinic visits, which happen 5 times a month at our clinic sites. And they are bilingual, bicultural staff who have also been trained by the state HIV program here in California. So we'll just go ahead and skip through those. I mean, that was one of the big differences with between that program and the one we were talking about before in diabetes. The lessons learned for us is that peer support integration doesn't always have to look the same. Because actually one of the differences between our HIV program is that, again, that it's all happening in the clinic, and that there are actually team meetings that for case review that are required for this program that weren't necessarily required for our diabetes peer support, because that was more challenging based on very different schedules for our CHWs. Anyway, so look for the best fit for the setting and the issue. For us, one of the key lessons that we have learned is anything needing more than 4 visits, which most of our chronic care management does require, should include some home or community-based intervention. It can all be done in the clinic because on average, our clinic patients only come in 3 to 4 times a year. And so if it requires more than 4, we shouldn't be doing some intervention in their home. And hopefully it becomes more of a reality with ACA and PCMH, the patient-centered medical home funding that has been available now through some federal grants. But that it is essential. It is helping us as a community clinic bridge that primary care practice, bridge our primary care practice with our larger community, and it is improving the lives of our patients. Thank you. And now, any other questions for myself or Ed?
Well, I just kind of want to spend the afternoon with you, hanging out, learning about how you grow these programs. I am an old Peace Corps volunteer, and in Thailand, where I was a Peace Corps volunteer, this model is also very much accepted by the community and sort of expected. So I think the cultural piece is quite important. I'm going to follow up with just 1 or 2 more questions that folks posed, and then recognize that we're coming to the end of our hour. One of our participants asked what the average panel size is for your peer supporters, and on average how many hours a week they might work.
We usually have about 6 community health workers per project, and that's if they're working part-time, or I guess it would be equivalent to 3 full-time for many of our different programs. And we do, and one of the things I didn't mention was that we, depending on what the issue is and what sort of contact it is that they're making, we do have some programs where they work as individual with the families, whether as an individual person or a group. And there's times and projects where we do have them work in teams. And so it depends on the health issue that we're trying to address and the intervention that we're trying to do.
Terrific. Well, I'm going to thank both Leticia and Ed for their terrific presentations. We learned a lot about the history of these programs and the evidence for how they work, and then we had the opportunity to hear how they work in practice. As we mentioned earlier in the call, these slides will be available for anyone who's interested within the next 24 hours. I just can't thank you both enough, and hope you keep up the terrific work, and we can grow our partnership between your organizations and the PCPCC. Like Leticia is pointing out, I do think that as PCMHs continue to grow, we have a lot of opportunities with models like this to improve the health of our communities. So with that, thank you everybody, and enjoy the end of your week.
Thank you.
Thank you.
Bye all.